Well, good afternoon. It's right afternoon, so I have to say afternoon. Everybody else got to say good morning. I have to say good afternoon. And I want to thank Carla Rubinger-Shepard for inviting me to be here. I see some friends in the audience, so my colleagues from Howard and other places, so delighted to be here. Since I stand between you and lunch, I have never actually been that speaker before you and lunch, so this is a new experience for me. I'm going to really try to go quickly through the things I've heard you've already talked about and give you a little bit of perspective from NIH, so a little bit of a different perspective than you've heard in your previous speakers from whom I've learned quite a bit. I include in all of my talks recognition of the women that came before, because I think legacy and history and honoring women is really important. On the left, you see Dr. Ruth Kirstein, the first woman director of an institute at NIH, and she was also the acting NIH director for a couple of months. The late Dr. Bernadine Healy, the first and so far only woman director of NIH. Senator Barbara Mikulski from the great state of Maryland, who recently retired but is active still in the policy space. Dr. Vivian Pinn, the first full-time director of ORWH. She was there for 20 years, and I was her deputy for several years. So our mission is threefold at ORWH. We're a trans NIH office located in the office of the director. So we want to expand women's health research, including across all those 27 institutes and centers, make sure that women and diverse populations are included in clinical research supported by NIH, and promote women in STEM. So I'll be talking about three major things in my talk. A little bit of background. You've heard all of this before, so I'll get to go through that really quickly. I do want to tell you about what NIH is doing, and I'll share what we're not doing in the space and some eye toward the future. So first, in terms of background, I think you all have heard all of this already, but this slide will help us to just remember that from a perspective that comes from breastfeeding's benefits to both the baby and the mother. We've heard a lot this morning on the benefits to the baby, which is absolutely important and critical, but I think that one of the ways that at NIH we might be able to push a little bit more is to weave this together in a little bit more of an integrated way. NIH, as every other federated organization, is subject to silos and the problems that silos come with. And everyone has my mission, my area. Well, our bodies are not really chopped up like that. Our lives are not chopped up like that. Child health, women's health, aging. I mean, an integrated perspective is what I think we need. So I won't belabor that point. Dr. Israel Ballard covered all of this very nicely in terms of looking globally. So just suffice to say, we're all aware that the breastfeeding duration is the shortest in high-income countries, and she highlighted that the breast milk bank locations, the milk bank locations, are the fewest in the places with the highest need. So there are lots of issues around where are things happening and where they're not, and why, and there are differences obviously across the board. I'm not going to mention this as well, but just the same data, but I did want to re-emphasize something Dr. Israel Ballard said, which is, what is the right metric for early initiation? What are the right metrics for these, and how are we assessing those? Those are huge gaps, whether we look at ever breastfed, obviously, versus breastfeeding exclusively at 6 months. There's really a lot of room for improvement in how we're assessing that information. We know that we're not meeting most of the criteria, and I want to change my slide. This is the first time I've used this slide, and somebody else made it for me. I asked them to make it. It says, most mothers in the U.S. do not meet AAP recommendations. How do you hear that? Right. I'm a mom. I don't like that. I'm like, is my fault, right? So I think we need to, again, in terms of culture change, which was already also mentioned, the way we talk about these issues, including academics, policymakers, anyone in this space is really important, and understanding of those factors. So we do have some success in meeting the Healthy People 2020 goals for breastfeeding initiation with a target of 81.9%. Unfortunately, that was in 2013. We don't have as many states meeting the goal for any breastfeeding at 6 months. So lots of work to be done, of course, across the U.S. But if you think about some of the factors that might be at play in the U.S., for example, there are not that many studies that help us understand some of the issues, especially around issues of needing to use medications for the women. So I'm coming at this from a perspective of the health of women, and that's the way we talk about women's health. We say the health of women because it's everything that affects a woman from head to toe. And there are not a lot of studies that talk about whether the need to use medications has a role in that breastfeeding use in the United States in particular. A few studies suggest that over half of women postpartum need at least one medication, not surprising, and that may contribute to breastfeeding initiation or duration. Here's a nice study, but it's very small, looked at the average number of medications breastfeeding women were using compared to during pregnancy, an average of 3.1 meds per woman during pregnancy and a significantly higher 4.9 during breastfeeding. Importantly, though, more than a third of the participants in that study were taking medications that were possibly or probably unsafe or with unknown safety. So that is highly problematic, right? And on the right there, you can see the top is months, so it just shows that there's no relationship with when you're doing this after birth, but there are these medications that are listed are the most common medications taken: NSAIDs, acetaminophen, multivitamins. I mean, things that you'd not be surprised about, but there are other psychotropic agents which are a big issue. So breastfeeding women may be forced to choose between taking a medication with an unknown risk for their baby or going without. Obviously, this is different across the world. But I wanted to highlight this issue because I haven't seen this highlighted in our discussions of personalized medicine at NIH or anywhere. And hypermetabolism of codeine is a specific example of a genetic polymorphism that results in that woman metabolizing codeine so that there is a significantly higher level than expected in the mother's milk that the baby would be exposed to. That's a serious safety issue. And these psychoactive drugs that I mentioned here in the middle, all of them have greater than 10% of the maternal plasma concentrations in the infant. So that's clinically significant. So here's another issue. When you hear about personalized medicine, you don't often hear about it in this space, right? You actually don't hear a lot about sex differences either, differences between men and women in the personalized medicine arena, where we can elegantly look at a molecular marker and treat that cancer. Well, I think that we have a lot more other work to be doing before we can really even do that on a global scale. So we don't have any data at all on the excretion of milk for 1/3 of the psychoactive drugs. And then the data that we have for 2/3, it's of not necessarily awesome quality. So if you look at how well NIH is doing in terms of including pregnant and lactating women in particular in clinical trials, so I'm switching gears a little bit, but this is the world that I live in, a lot of trials exclude pregnant women. Okay, we might understand that, depends on the circumstance. But a lot of trials exclude lactating women, and a lot of trials don't even talk about lactating women. So there's no comment on it, so that's problematic, right? Because people don't know what to do. So we're trying to move from a posture of excluding people to presumed inclusion and then excluding as needed. Because if you look at this publication by the NICHD director and deputy director recently in JAMA, putting together all the exclusions, they came up with 58% of the U.S. population are typically excluded from this research. This was phase 3 and 4 clinical trials that were supported by NIH. So that is clearly a problem, since those trials are supposed to be informing the use of those medications in everybody. And if you look at the literature in terms of what are we studying, what is NIH supporting, what are we studying, what's the knowledge base for the conditions that affect women of childbearing age who might be pregnant or lactating, what is our understanding? And I want you to highlight that, look at that low bar, which is low milk supply. Like, really? We've got some good work in diabetes, preterm labor, we need that. Mental health, we need it. Vaccines, we need it. But there's a real disconnect here between, for example, hyperemesis, asthma, and low milk supply is the lowest. So what are we doing in this space? Very recently, or not so recently, but 2 years ago, 21st Century Cures Act established the Task Force on Research specific to pregnant and lactating women, okay? So this task force is focusing on the women, not the babies, but it included lactating women, which is very unusual for these types of task force. And the purpose of the task force was charged to give guidance to the HHS secretary on identifying and addressing knowledge gaps regarding safe and effective therapies for pregnant women and lactating women, including the development of such therapies. And so a variety of folks are on this. The task force actually just had its 4th meeting and is drafting its report. Here's where we are on that timeline. And so some of this has been reported publicly, and I'll share a little bit with you. But September 2018, the final report is supposed to go to the Department of Health and Human Services. So we'll see what comes of that. I will share with you, this is kind of Dr. Bianchi came and spoke to our advisory council. That's my group of outside advisors that support the Office of Research on Women's Health, and she shared with us this really disturbing information in that part of that task force work, they wanted to see how much money we were spending on, maternal health, pregnancy, and there wasn't a budget code for maternal health or a budget code with those RCDC codes. These are like tying a dollar to a specific disease. That's what those codes are. We have other ways of tracking it, but this is the most sophisticated way of tracking these dollars, and we didn't have a code for that. I am embarrassed to say that I didn't know that we didn't have a code for this, and so she highlighted it and made sure that now NIH has these codes for maternal health, reproductive health, and pregnancy. There isn't a code. There is a code. There's a code for breastfeeding, lactation, and breast milk as well. So those all got established in 2018. So going forward, you guys will be able to track the spending there. So if we look at the different projects that we fund among different institutes and centers, this is just a Venn diagram that highlights some projects are just on pregnancy, some are pregnancy and breastfeeding but not maternal health, some are on breastfeeding only, and so it's just a standard Venn diagram. I'm going to highlight the ones that are circled there that are relevant to our conversation today. And if you look at FY17, there were 159 projects in that space, $91.7 million supported by 20 different institutes and centers, including our office. The 3 institutes that supported the most grants are the National Institute of Child Health and Human Development, the Institute on Allergy and Infectious Disease, so that's the vaccine work, and Diabetes and Digestive and Kidney Diseases and IDDK. But only 9% of these grants were directly related to medication and or supplementation use by lactating women. So we still have lots of work to do. And if you look at research related to pregnancy, lactation, and breastfeeding and want to see where that money is coming from, so you might be able to tell investigators, here's where you should go, and NICHD is the number one. And that makes sense. It's right flush in their mission area. But on the right are all these others. So there are other ways and other institutes that are supporting this type of research. And I want to give you a few examples of them so you can get a flavor of what NIH is funding in this space. So one of them is addressing this incredible opioid epidemic in this country. And this is this is an R01, so the coin of the realm, gold standard, looking at how maternal buprenorphine and naloxone treatment during the perinatal period affects the fetus and the infant. It's funded by the National Institute on Drug Abuse, and they're looking at buprenorphine and naloxone treatment of pregnant women, so that while they're pregnant, and it's a really promising treatment because it has decreased potential for abuse and potential increased adherence. So there apparently is no available prospective assessments of the maternal, fetal, and infant functioning after maternal buprenorphine and naloxone treatment, which I found incredibly surprising that we have no data on this. And they added a lactation study component. So they're going to be looking at the concentration of buprenorphine and naloxone in breast milk and in maternal and infant plasma for breastfeeding women who are receiving this treatment. And they'll also be looking at neonatal abstinence syndrome parameters and neurobehavioral profiles. So that's a pretty comprehensive examination. Here's another example. This is funded by the Neurology Institute and is addressing a recent American Academy of Neurology guidelines note citing the critical lack of data in understanding anti-epileptic drugs and use in pregnancy. This study is called Maternal Outcomes and Neurodevelopmental Effects of Anti-Epileptic Drugs. It's a multi-center study that's using a prospective observational parallel group cohort design. They're going to be able to directly measure exposures, as in blood levels, in breastfeeding infants for a variety of anti-epileptic drugs that their mothers need to take, and they're going to be testing if breastfeeding, when taking those, the mothers taking those medications, adds risk to the child's verbal, intellectual, and other cognitive abilities beyond in utero exposure. So it's a really nice design that's going to be able to parse some things out and help us so that we can answer these questions as clinicians when our patients ask us questions, and many times there's just no data to answer the question. This one is looking at the infant gut microbiome. I'm sure you've heard lots of stuff about the microbiome, but you also heard earlier mention of necrotizing enterocolitis, obviously the leading cause of lethal gastroenteritis in the NICU. And breastfeeding protects against necrotizing enterocolitis. And so this study is going to look at the maternal diet, so what the mother's eating, her gut microbiome, so what's in her gut, the microbes, what's in the milk, the microbiome there, and then what's in the gut of the baby who receives that milk. They're also using some really, really elegant technological advances to look at the IgA that the mother puts in her milk and how that interacts with the bacteria in the baby's gut. Really incredible high throughput technology. And the only way you can do this is these types of studies. So here's an animal model. I wanted to be sure to share some of our basic science work. This is a KO8, so it's a career development award for somebody who's trying to be in this space and choose this area. And it's looking at activation of a particular transcription factor that's involved in inflammation. Let's just keep it at that level, and looking to understand how that particular, and this is toll-like receptor 4 mediated inflammatory signals play a role in necrotizing enterocolitis. So if we can understand some of that, maybe we could design something that could be added, that could be used instead of, not in place of, or in addition to, let me just say, breast milk that would be helpful for those infants. Another study is looking at improving maternal to child HIV transmission, and this is in Malawi using option B+, which allows mothers to receive lifelong antiretrovirals. And so it's a really nice design as well. So I wanted to add that. That's funded by our Fogarty International Center, one of the institutes at NIH. And the last example here is an RO1 funded by the Child Health Institute. It's looking at improving infant health by increasing low-income parents' adherence to infant feeding guidelines. And it bundles it with safe sleep practices and secondhand smoke exposure education. So it's a community-based participatory research model. This is in New York, and it addresses some of the issues related to infant feeding as well. So here's some of the examples of funding, specific research funding. Here's another example called PregSource, which is a crowdsourced platform. I'm sure you guys know about it, but it's a little different for NIH because we're slow to get into this space sometimes, and crowdsourcing is specific sections on that platform now for me after pregnancy, breastfeeding and pumping. They're going to be adding a medication tracker so that breastfeeding women can add the medications that they're using, and that's going to go up to 36 months. So I encourage you to take a look at that. Many people are aware of this transfederal public-private partnership that's resulted in Text for Baby, but I want to highlight that they're continuing to expand how Text for Baby is being used. It's been evaluated on multiple times. It's been found to be effective in delivering messages to women. It's focused on the baby, but they've actually moved beyond that to look at ability to get mothers to get flu vaccines, for example, and they've been able to measure whether these texts work. They've now sent 62 million texts over the last several years. And so that's one other example. NICHD's long-term Safe to Sleep campaign, I'm just highlighting this because it is directed at the grandmothers. And so I thought that was a different way of highlighting their strategies. And I think we're going to have to be really creative and understand the audiences and to whom we're speaking and working if we're trying to change the culture around breastfeeding. And then just on a more very important but database kind of issue, the National Library of Medicine provides for LactMed, a database that talks about the data that, provides the data that we know about medications or environmental exposures or chemicals in breast milk and their effects. And so that's at least one place that is a government-supported database that information can be obtained. And so as we move forward, I mentioned that Pregnant and Lactating Women Task Force, they recently put forth 15 recommendations. I don't think these are final because they haven't finally gone to the secretary, but they published them, so I'm sharing them with you because they're already in the public domain. They're really around research, of course, including and integrating pregnant and lactating women, increasing the quality of the research, expanding the workforce of people that are in that space with expertise, and developing and implementing evidence-based communication strategies with healthcare providers. So that certainly could involve the breastfeeding piece as well. Liability is a huge issue, especially in this country and elsewhere. Reducing liability to facilitate developing that evidence base would be truly helpful. That's going to require lots of heads, and we haven't solved that problem to date. So really would be great if we could get some different ideas on that area. Implementing proactive approaches to protocol development. So if we can figure out a protocol or study design that we agree on that is ethical, that is okay, with these caveats or these safeguards in place, can we get some best practices and lessons learned? Developing programs to drive discovery and development of new therapeutic products for conditions specific to pregnant and lactating women, specifically for the low milk supply issue. Optimizing registries for pregnancy and lactation in terms of them being user-friendly, the right data elements. Can we share that information? Can we maximize the utility of those? And so all of these recommendations are aimed at changing culture. And culture's pretty hard to change. Culture's hard to measure. You can, though. And it's hard to change, whether it's culture in an office, culture in an organization, or culture around this really super important issue. And I would end by saying that I'd love to hear, I'm not going to be able to stay too long, I'll be able to stay for a little bit after this, but I would love to hear your input on whether you think an integrating interdisciplinary approach might be useful in the policy space. At NIH, we are in the research realm. We inform policy. We make policies about research. We don't make policies about breastfeeding. We interact with the biomedical enterprise as well. But that trying to link the health of these babies and the health of the woman who is lactating and providing that breast milk to the health of future generations, I think it's the right time to do that linkage, because now that people in our realm, in the basic science realm, think that epigenetics is like incredible, the fact that all of these things that happen to you, it's not just about your genome, it's all how your genes are expressed, and that all these things are happening to you, be it the stress you had this morning when you couldn't get on the metro, or the stress that you have because you have to provide for 5 kids. Those things are affecting your genome. They're affecting your body, and those things are passed on. So you're affecting future generations. And I would say, women are truly altruistic. I mean, the fact that women's bodies can make a baby, not by themselves, but had that baby, that's pretty awesome. And they're extremely, if you talk to women about why they participate in research, because that's the only piece I can tell you, they do it for knowledge that will benefit other people. They know, because we tell them, we're not sure that this information is going to help you. You have stage 3, blah, 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 whatever. We have equipoise. We do not know if this is going to work. That's the ethical way to do a research study. You don't do research studies when you know the answer, right? So we don't know. We would like you to participate. These are the risks. These are the benefits. If you ask them why, that's what they'll tell you. For future generations, for my daughter, for my community, for my granddaughters. So that's another strategy I think that we need to bring in. I don't know if there are any communications experts here. Are there? Yeah. Yay, there are. The one who is nodding back there giving me all that positive vibe. Thank you. We have to do better with how we deliver our messages. And I believe in communications, that we really have to think through this more carefully, especially now. And I'm not over, so I can just take one moment just to say, it's a tough time. It's a tough time for science. It's a tough time for data. It's a tough time for women, right? More than ever, we have to find new ways of working together. More than ever, we have to reach across whatever bridge. That was a great slide, by the way. There are a lot of bridges. Actually, the bridges that I see are farther apart than that. So I can't even lay across the bridge and reach the other person. But we really have to do things differently. And I have never spoken on this topic. So thanks, Carla, for inviting me. it was great to be able to share some of NIH's information. NICHD is a wealth of even more information, but I wanted to share with you that potential strategy for interdisciplinary and integrated approaches, and to share a little bit of our programs with you. Thank you so much for your attention. I appreciate it. Ooh, I made up all your time.
We do have time for questions. So.
Awesome. Quiet. They're hungry.
Thank you, Dr. Clayton, for your leadership.
It's Alina. Hey, good to see you. You've got all these amazing talks coming up. You're talking, CDC's talking. I was like, why do they even want me to talk about anything? They've got everything already there. So I'm sorry I won't be able to
We
hear
have
you
a
talk,
lot of
but-
talkers, but we need more solutions. So thank you for your leadership. And I know this is really a difficult time. And we've had these discussions a lot around women's health research. I have kind of two issues that I would like to hear your perspective on. One is that we've kind of moved to a world where insurers, policymakers, they want the evidence. And so, what can we do kind of as there are people here who are researchers to really kind of push that. You looked at the number, I always look at the, follow the money.
Yeah.
And it's great that we now have some codes and can look at these issues. But what can the community do here to really kind of steer NIH in a direction where they're really going to prioritize this issue? We've had these battles around women's health generally, and this is kind of a sub part of that. But the multi-generational aspect, I think, is very appealing in many ways to policymakers. So I wondered your thoughts about that.
So I think we need to be strategic, and you have the voice of your members of Congress that ask us questions regularly and send us, missives and things that they want us to do. And so I would say that is number one pathway for change to come. This is from the 21st Century Cures Act. That task force would not have happened. Okay. Recognizing it's a different time now, but that is a pathway. But before you go that pathway, I think what's really important is to have a honed, clear message that is designed for who you're talking to. And there are a lot of groups, I'm not talking about this cause, this issue right now, in the health of women space. There are all these different disease groups. They all are doing their own thing. They're all important. They all have great people working for them. But, if you advocate for lung disease, but you're not advocating for heart disease in women, how helpful is that? It doesn't work like that. Our bodies don't work like that. I have not seen integrated perspectives. Yes, you've got to have evidence, and it's great. We're all in this room about data. We want data. But we also recognize we don't have the data for everything. We're not going to wait till we have every piece of information to do something. I'm not of that mind that I love data. I'm a scientist. I'm a clinician. But there is interpretation of data that makes data become evidence. Data is not the same as evidence. Data is just information. How you interpret it makes it evidence. How you interpret information includes all the perspectives of people in this room. There's a gap. There are not safety standards by WHO for milk banks. I didn't know that. So, those are things that need to get out. But I think also, Alina, if you're going to kind of develop a message and a strategy, you need a tiered approach and you need to be realistic. So you asked me the question, so I'm going to give you my answer. You need to figure out something that actually can be done, right? Because if you ask for this right now, you're not going to get anything. So if you can find something that can be done, that can be built upon, and if you can develop coalitions that are unusual, partnerships, that would be my advice. It's just a different world. And so we don't want to move backwards. We want to move forwards, and we're holding on to be able to move forwards and not lose ground. And so creative coalitions, and then having those tough conversations about what is most crucial to do right now. Not what's most important from one group's perspective. Those are tough discussions, and you need a skilled facilitator who has no skin in the game at all to manage those conversations, because everyone's losing something. But the whole field isn't losing if you don't all lose ground and lose all the money that's even in this space, and it's not even that much money for over half of the population to address the issues that are important to us. And I didn't share this stat because I didn't finish reading the paper, but this Lancet paper that highlighted increased cardiovascular death risk for women who have preterm infants. I didn't get taught that in medical school. It's new, but anyway, it's new. So, but that's not a perspective that you hear a lot of people talk about, right?
So Ruth Peterson from CDC, it's a pleasure to meet
nice
you,
to
and I
meet
can't wait
you.
to get on speed dial with you after this from some of your comments. But I think one of the things that at CDC we work with the grantees across the country, but we also work with some key partners, and part of it is doing exactly what you just mentioned. How do you communicate all the great evidence that comes from NIH? CDC we see ourselves as implementation scientists, and we have the boots on the ground with many organizations that are represented in this room. But I'll give you an example of where I want to be on speed dial with you after this. So we just released information on infant and toddler feeding, because I think feeding your baby is one of the scariest things any of us have ever done. And it's even scarier when you don't have the resources that many of us had. And the woman shaking her head right here, Lucy Sullivan, is the executive director of 1,000 Days. And CDC's paired with 1,000 Days to help communicate in a way that we can do as from a scientist perspective, and then 1,000 Days can carry it out in some other networks. So we would love to triangulate with some of what you've been talking about. So you said you were leaving. I would have waited until lunch to tell you.
No
but
worries.
just thank you for your presentation. It was really important. And medications during pregnancy are, again, another ratchet up on the fear that women have at the local level for whether or not they're a good mom or providing the best for their baby. So we appreciate what you're doing at NIH. Thank you.
No, thank you, Ruth, and I'm sure your presentation will also be awesome. I'm so sorry I'll miss that. That means I definitely want to connect with you too, so you can share that information with me.
Hi there. My name is Allison Stubbe. I'm a maternal fetal medicine doctor in North Carolina. And I just so appreciate your recognition that human bodies don't work in silos. I've been leading with some colleagues at UNC work around the fourth trimester and the challenges that moms face after birth. And while breastfeeding is clearly one of those that intersects with sleep, with sex or not, with mood, with all sorts of different kinds of issues. And I think the challenge is there isn't an institute of moms at NIH. There's an institute of child development, but the mom becomes the thing that makes the milk as opposed to the subject of study.
I hear you.
I would love to see an NIH RFA around the management of lactation as mom physiology, as opposed to a way that breast milk gets to babies. And these issues like low milk supply and pain, because I am so sick of telling the mom in front of me, well, I got nothing. Sorry, you don't have enough milk. Which is basically where we are. So I am pleased that that's on the radar, and I hope to see that as a funding source in the foreseeable future.
Yeah, thank you for your comments. That slide I got from Diana Bianchi, the director of the National Institute of Child Health and Human Development, who spoke about that at our advisory committee. So, and maternal health is technically in that institute, right, with child health and all of human development. And they will be developing a new strategic plan. So what I would say is also for ABM, get ready. So when the request for information comes out, you will have positions to put forward. Get your colleagues to submit information. We look at that seriously. We consider all of that information. That's a real opportunity for your voices to be heard. And I would love to connect with you more, because the health of women, I'm saying that very intentionally because it's right along those lines. And I love that term, the fourth trimester. I wasn't familiar with it. So thank you for sharing that with me. We can't say either or. It's both and, right? So.
Can I make a comment about codes? Your comment about codes. There are codes that deal with breastfeeding, but in my world, most of the time they won't pay for them unless you actually argue the point with medical directors. And I think, especially in primary care, you sometimes see we bill for codes or they don't bill for codes, so we don't have good data because we don't bill for the codes, right. Because they won't pay for it. So you have to argue with the medical directors of the insurance companies, and until the insurance companies get this to be a quality measure or a quality data, we're going to get poor information from them.
Right. certainly out of my space, but I would say that that contributes to the landscape, and that maybe a description of the landscape showing gaps in all of these, challenges in all of these arenas that surround breastfeeding, gap here, gap in funding, support for the visit, if there's no code, or if the code is going to be subsumed by another code that might be more beneficial for somebody to bill for. There are all kinds of issues there, which I certainly can't comment about, but I would say that, again, an integrated perspective where you're saying this is where we are, what's a reasonable strategy that might be foundational for building upon in the future would be one way. And talking to each other so that we're all speaking different languages too. We speak the language of our field and our background, and so having some of those conversations like this, exactly like a summit like this is your 10th year. So I wanted to say congratulations on being 10. At 10, you still believe you can change the world. So congratulations to ABM and to the summit. And thanks again for inviting me.